Good morning, everybody. Welcome to our 100 use case subjects in neurosurgery. This is an educational program that will cover main issues in neurological surgery in a period of 3 years. We will attempt to complete 100 lectures of the most relevant aspects of neurosurgery. And today, the first subject that we're going to discuss is the pathophysiology of subarachnoid hemorrhage and vasospasm after the rupture of intracranial aneurysms. This is mainly an update of the concepts in the pathophysiology of vasospasm under the light of the findings that have been revealed by clinical trials in the use of clazosentan and imodipine for the treatment of this condition. I don't have any conflict of interest to disclose for this presentation. Very interestingly, 500 years BC, Hippocrates described in his aphorisms a condition characterized by sudden onset of headache. And he said, when persons in good health are suddenly seized with pains in the head and straightway are laid down speechless and breathe with stertor, they die in 7 days. And it's striking how he was able to capture the clinical course of these individuals and to point to that specific window in time in which they become very sick and usually die, that is the period of 7 days. And even though he didn't know what was the cause of these events and the pathophysiologic events involved with it, he was able to clearly describe something that looks pretty much like an individual suffering of a subarachnoid hemorrhage after the rupture of an intracranial aneurysm. Sudden onset in a patient that was until that moment usually healthy of headache that is followed with neurological deficits, and that by day 7 frequently ends with the death of that individual. And even though it wasn't until Galeno who first described an aneurysm, and much later that an understanding of the rupture aneurysms occur, and the works of Eckhart in the 50s to understand some of the principles of vasospasm, subarachnoid hemorrhage still is a very serious problem and affects more than 30,000 North Americans each year, representing 5 to 10% of all stroke cases. As you will know, 50% of these individuals unfortunately die during the acute ictus, and those that survive have a very complicated course. 20 to 30% of them die or are disabled, and the primary reason for this to occur is the development of the syndrome that we know as vasospasm. Subarachnoid hemorrhage affects people of all ages, from childhood to old age, but usually the peak is around age 40 and 60 years. In a very interesting review of 51 epidemiological studies describing 58 study populations in 21 countries, Ruiz et al. Described the incidence of subarachnoid hemorrhage per age groups, and as you can clearly see, as people advance in age, there is an increase in the incidence of subarachnoid hemorrhage, and the peak starts around age 40 and is sustained up to beyond the age 75 and 85. Now, another aspect of this study that is of relevance is that the predominance of subarachnoid hemorrhage in women doesn't become evident until the age 40, where clearly they take a stand on top of the incidence of subarachnoid hemorrhage in men. And in these groups, the prevalence remains high until older age. Now, as we have mentioned before, subarachnoid hemorrhage affects those aged between 40 and 60 years, which means there is a group of age usually younger than other individuals with ischemic stroke or with intraparenchymal hemorrhage. This is very important because it implies a significant toll in terms of productive life years lost and significantly higher costs in the acute and follow-up periods of these patients. In this study published in Cerebrovascular Disease magazines by Lee and his colleagues, the cumulative total lifetime cost in the Kaplan-Meier sampling average curve clearly indicates how subarachnoid hemorrhage that is described with the squares is almost, or represents almost the double of the cost of other forms of stroke as intracerebral hemorrhage or ischemic stroke. And this occurs despite the new technologies that we have and the recognition of the importance of obliterating the offending aneurysm early in the course of the disease. So if we discount the deaths and morbidity produced by the acute ictus, and despite early treatment of the intracranial aneurysm, up to half of the treated patients develop a syndrome of focal and or cognitive deficits due to cerebral vasospasm, delay ischemic neurological deficit or symptomatic vasospasm between the 3rd and 21st day after the subarachnoid hemorrhage. Therefore, vasospasm constitutes the single most important cause of morbidity and mortality in patients whose ruptured aneurysms are successfully treated. Now, since the work of Eckert in the 50s, the center of the attention in the research field and the understanding of the pathophysiology of this syndrome has been the contraction or spasms of the arteries. In 1951, Eckert was the first one demonstrated in cerebral angiograms of patients with intracranial aneurysms the presence of this phenomenon of contraction of the arteries. And these findings were further characterized by Weir in 1978. These images taken from the original paper of Eckert demonstrate on the left side in the image A and C, a spasm of the supraclinoid carotid artery in an individual with an ICA bifurcation aneurysm that is indicated with the large arrow. In this particular case, and at the time it was the common practice, the aneurysm was not treated, and the patient was lucky enough to survive, and 1 month later, the images B and D show a recovery of the size of the vessel. So, since this finding of the presence of angiographic spasm of the arteries in patients with subarachnoid hemorrhage, the axiom that subarachnoid hemorrhage produces arterial narrowing and in turn ischemia causing infarction and poor outcome became the center of all the research efforts and clinical efforts for the treatment of this condition. Now, in that line of thought, many efforts have been made to develop therapeutic interventions that can prevent or resolve the development of a spasm of the intracranial arteries. And the two molecules that you are seeing in the screen are the molecules of the nimodipine and the clazosentan, two of the medications that have been tested for the treatment of this disease. These findings are important because thanks to the specific characteristics of the results of both the clinical trials for nimodipine and those for clazosentan, we have today a different understanding of how vasospasm or delayed neurological deficit associated with subarachnoid hemorrhage occurs, and a better understanding of why there is these two classically taught forms of vasospasm. Vasospasm angiographically detected that can be seen in as much as 70% of patients, and another form of vasospasm known as clinical vasospasm that affects usually only 30 to 50% of patients. But as we will see through this lecture, maybe there is more than a spasm of the arteries, or most likely there is more than a spasm of the arteries involved in this process. But let's start first with a better understanding of what occurs in the spasms of the arteries. And to understand that, we need to look at the physiologic conditions that regulate the contraction of the vascular smooth muscle in the arteries of the brain. In that way, we can see which are the mechanisms that are altered with subarachnoid hemorrhage and how both nimodipine and clazosentan had been thought to be relevant to prevent this syndrome to occur. So let's talk first about the physiologic smooth muscle contraction. And as you will know, for this contraction to occur, the myosin light chains need to interact with actin filaments. This interaction produces the fibers of actin to go inside of the fibers of myosin and the muscle to contract. And the myosin light chains interact with actin thanks to the phosphorylation that they suffer, which is due to the activation of the myosin light chain kinase. This process is due to the activation of the calmodulin, a process that is mainly controlled by the increased intracellular concentration of calcium. This increased intracellular concentration of calcium occurs in physiologic conditions by depolarization of the smooth muscle membrane with opening of calcium channels, and depolarization that extends into the sarcoplasmatic reticulum, which also release calcium. Now, these calcium channels open by the interaction of the protein G coupled receptors, which also in physiological conditions have the control of an endothelin contraction factor, that is the endothelin 1, produced by the endothelial cells. And the endothelial cells play a very important role in maintaining the tone of the smooth muscle cells, both by releasing the endothelial contraction factor, but also by producing some of the endothelial releasing factors. Now, once the contraction of the cells occur, the myosin light chains get to be desphosphorylated, and this is due to the myosin light chain phosphatase. In addition, the myosin light chain kinase is inactivated due to an increase in the activity of the protein kinase A, which acts by increased levels of cyclic AMP. Now, as I mentioned before, the endothelial cells play an important role in maintaining the tone of the smooth muscle cells. And the other side of the coin is the production of the endothelin releasing factor, that is the endothelial nitric oxide synthase. This enzyme is going to produce nitric oxide, which is important for the activation of the guanylate cyclase, which increase the intracellular levels of cyclic GMP, which are going to produce sarcoplasmatic reticulum reuptake and reduction in the intracellular concentration of calcium. So in physiologic conditions, the smooth muscle can contract in the vessels, but then gets to be released by the mechanisms that are shown in the screen on red. Now, during subarachnoid hemorrhage, the vascular smooth muscle contraction occurs in pathological conditions in two periods, an acute period and a delayed period. The initial phase of vasospasm after subarachnoid hemorrhage is calcium dependent and is due mainly to the abnormal depolarization and opening of the voltage-gated channels that induce an increase in the intracellular concentrations of calcium. However, this phenomenon doesn't last too long. And after the acute period, what really goes on in the generation of the syndrome of vasospasm and the delayed neurological deficit is due to the sensitization of the contracting mechanism to calcium. And this occurs by several mechanisms. The protein G coupled receptors get to be activated by the endothelin 1, which is produced in excess in patients with subarachnoid hemorrhage, as has been demonstrated in multiple studies, both in CSF and in serum of individuals with subarachnoid hemorrhage. And the protein G coupled receptors are not going to only open the calcium channels, but are going to also activate the protein kinase C. And by activation of the protein kinase C, several activated protein kinases are going to occur, including the activation of the Rho kinase, which inhibits the myosin light chain phosphatase, removing the possibility of the phosphorylation and increasing the permanence or persistence of contraction in the smooth muscle cell. In addition, the protein kinase C is going to activate the mitogen activated protein kinase, and by way of this activation and by direct effect is going to induce phosphorylation of caldesmin and caldesmon, both of which prolong the phosphorylation of the myosin light change, inducing persistent smooth muscle contraction. Now, understanding that this is what occurs in the delay period when the clinical vasospasm presents, 2 attempts of therapeutic intervention have been successful to the point of clinical trials to try to block this chain of events. One of those is the use of the clazosentan, which is an intravenous endothelin receptor antagonist, and the second one is the use of nimodipine, that, as you well know, is a calcium channel blocker. However, some of the peculiar results of the clinical trials in these 2 medications bring special questions and lights into the pathophysiologic process of vasospasm. Let's talk first about the nimodipine trial. Both the American and the British trial and multiple reports and meta-analyses have shown that nimodipine doesn't appear to decrease the incidence of angiographic vasospasm. However, it improves the outcome of patients after subarachnoid hemorrhage. On the other hand, the clazosentan effectively prevent and reverse arterial narrowing, as it was shown in a randomized double-blind placebo-controlled multi-center phase 2A study published by Jacobsi in the Journal of Neurosurgery. And as you can see in the graphic, the incidence of arterial spasm was significantly reduced as the dose of clazosentan was increased from 1 milligram to 15 milligrams, and in all the doses this finding was significantly different than in those patients treated with placebo. This clearly provided evidence of what was thought was a very effective treatment for vasospasm. However, the subsequent multicenter conscious trial, despite significant reductions in the angiographic vasospasm, failed to show any effect on the long-term outcome of these patients. And the graphic that you are seeing are between the evaluations by the investigators themselves and the central assessment of CT scans and MRIs of individuals that were treated. And basically what it shows in the event rate is that there was not significant difference in morbidity or mortality of these individuals treated with clazosentan, despite the fact that the angiography showed less spasm of the arteries. Which brings then a very interesting question. We have in one hand a clinical trial that shows no impact in angiographic vasospasm, the nimodipine, however improvement in the clinical outcome of these patients, and in the other hand a second clinical trial that shows a very significant impact in the spasm of the arteries in angiography, but didn't have any effect in the clinical results of the patients, which suggests that maybe the spasm of the arteries is not necessarily the center of all the pathophysiologic events that occur after subarachnoid hemorrhage and that produce the syndrome of delayed neurological deficit. What I like to think is that we need to switch from an spasmocentric model of understanding of subarachnoid hemorrhage and vasospasm to a model with the spasm of the arteries surround other events and make part with another events of the complete pictures of what occurs in vasospasm after subarachnoid hemorrhage. Thanks to these clinical observations, we can point 4 main new concepts in the understanding of vasospasm after subarachnoid hemorrhage. First, arterial narrowing is not the only cause of delayed clinical deterioration. Second thing is arterial narrowing is not necessarily multifactorial. In fact, the blockage of endothelin 1 was quite significant in inducing release of the angiographic vasospasm. Now, that increase in the endothelin-1 activity may actually be an effect of a single factor, as we will discuss in the following slides. But the entire picture of the late clinical deterioration most likely is multifactorial, and the contraction of the arteries is only one of those multiple factors. Now, I said before that actually the arterial narrowing is not multifactorial, and that also has been observed for a long time. There is clear understanding that the degree of contraction or spasms of the arteries is closely related to the amount of blood in the subarachnoid space. And the main reason for that is that most likely the main factor inducing the contraction of the arteries is the hemoglobin. And the effects of hemoglobin and ferrous hemoglobin released from the subarachnoid clot leads to the late arterial narrowing by mechanisms that are multiple and in fact not completely understood. Hemoglobin, as we will see, can induce neuronal apoptosis and most likely can induce also, through some of its degeneration processes, death of endothelial cells. The second effect of the hemoglobin is the scavenging effect with nitric oxide, which, as we discussed before, is the main relaxing factor of the balance that normally the endothelial cells should protect and conserve. The third one is that hemoglobin per se induces an increase in endothelin-1 levels. And thanks to the action of the superoxide dismutase and the absence of catalases in the extracellular space of the smooth muscle layer of the arteries, the hemoglobin is going to produce a series of oxidative stress factors that are going to damage the smooth muscle cells and the endothelial cells. This free radical production is going to lead to lipid peroxidation of the cell membranes with damage of these cell membranes. And there is going to be also associated abnormalities in the potassium and calcium channels, and even induction, thanks to the hemoglobin end products, of upregulation of genes, as we will discuss. So hemoglobin can produce apoptosis of neurons, but some of the products of the hemoglobin, which can reach the endothelial cells both by the degeneration of microvascular clots that can form due to a stop flow phenomenon, as we will discuss, as well as by diffusion of these factors through the smooth muscle layer, as we will discuss also in further slides, may induce apoptosis of the endothelial cells. This microscopic electronic microscopy photography from John Sang shows degenerative changes in the endothelial cells. You can see vacuolization of the endothelial cells that is indicated by the arrowhead. Now, the damage to the endothelial cells is going to produce several abnormalities inducing blood-brain barrier disruption, which is going to induce vasogenic edema. It may also lead to a decrease in the production of endothelial-dependent relaxing factor as the nitric oxide, and it has been speculated to aggravate vasospasm locally, if not generally. This is going to be further aggravated by denuding the vessel of endothelial cells, which is going to expose the vessel, and specifically the smooth muscle cells, to a host of vasoactive and toxic metabolites, which can also aggravate vasospasm. So hemoglobin and its toxic effects is going to play a very important role in the damage on the endothelial cell and in the cascade of events induced by this damage. Now, as I mentioned before, nitric oxide is important to keep the basic myogenic tone of the cerebral arteries. And the hemoglobin is going to play an important role scavenging nitric oxide, trapping it, and making it less available for the smooth muscle cells to induce relaxation of the cells. In primate models of subarachnoid hemorrhage, Plura and his group reported that immunoreactivity for neuronal nitric oxide synthase was virtually absent in the nervi vasorum of MCA arteries on individuals with spasm. And there is new interesting concepts associated with this. We mentioned how the hemoglobin, by inducing endothelial cell death, may induce also a reduction in the levels of the endothelial nitric oxide synthase. But Kurana and his group in the Journal of Cerebrovascular Blood Flow and Metabolism published a very interesting report where there may be pointings towards a genetic predisposition for vasospasms based on a significant reduction in endothelial nitric oxide synthase gene promoter activity, which was significantly more common in patients with cerebral vasospasm than in those without it that suffer subarachnoid hemorrhage, which could give us light about the phenomenon that we observe frequently from the clinical perspective, that is, not everybody gets vasospasm. A significant proportion of patients do, but individuals with much amounts of blood in the subarachnoid space not always get vasospasm. And maybe one of those reasons could be a genetic predisposition, which link could be the endothelial nitric oxide synthase gene promoter activity in those individuals predisposed to have the syndrome. Finally, the statins can act not only by producing anti-inflammatory effects, but they have also been linked to upregulation of the endothelial nitric oxide synthase expression in the endothelial cells. So in addition to the anti-inflammatory effects that they may play and the control that they may induce by reduction of the leukocytes induce inflammatory response, they may play also a role in preventing or helping individuals with vasospasm by inducing an increase in the endothelial nitric oxide synthase. Now, elevated endothelin-1 levels have been extensively published in cerebrospinal fluid and serum of patients and animals with vasospasm. Clazosentan was the ideal magic bullet to treat this condition because selectively blocked the receptors for the endothelin-1. However, as I mentioned before, moderate to severe angiographic vasospasm was significantly reduced in a dose-dependent manner from 66% in the placebo group to 36% in the high-dose clazosentan group. Despite this reduction, there was no significant effect on the outcome based on the modified Rankin scale at 3 months. And the endothelin level ones have been proven are elevated thanks to the presence of hemoglobin in the subarachnoid space. Now, something that is very interesting is how this hemoglobin in the subarachnoid space, or how the endothelin that normally is produced by the endothelial cells, are going to reach the smooth muscle cells and produce the syndrome of vasospasm. Well, I think one of the most interesting suggestions of how this may occur has been published by Asano and his group, because once the hemoglobin and the oxyhemoglobin is delivered in the subarachnoid cloth, the oxyhemoglobin and the oxygen radicals produced by it can diffuse through the adventitia into the extracellular space of the vessel. Now, in both the subarachnoid cloth, in the subarachnoid space, and in the extracellular space, there are superoxide dismutase molecules that are going to produce degeneration of these oxygen molecules into hydrogen peroxide. A main difference occurs inside of the vessel in the extracellular space in between the muscle cells, because in that location there is no catalases that normally would transform the hydrogen peroxide into water. On the opposite, the presence of hydrogen peroxide and induced by the presence of oxygen and the oxyhemoglobin are going to produce by the iron catalyzed Haber-Weiss reaction and by Fenton reactions the presence of hydroxide radicals, which play a very important role in the lipid peroxidation and damage of the membranes, as we have mentioned before. Now, Hemoglobin also has been linked to abnormalities and alteration in the functional gene expression. In this very interesting study published by Sahara in a canine model, functional network analysis of the gene expression in a vascular artery vasospasm model were made. And in the graphic on the right, the nodes represent genes, with their shapes representing the functional classes of the gene products, and the edges indicated the biologic relationship between the nodes, which include physical and functional interactions. The color indicates up in red and down regulation in green. And those genes related to cell communication, host pathogen interaction, and defense immune protein activity were significantly overrepresented, which suggests strongly that the presence of subarachnoid clot induces in the cells exposed to the blood an increase in their ability to respond to inflammation or to host pathogen interactions, with an increase in an immune response, which of course will play an important role in further damaging the vessel and producing further vasospasm. And here a point that is of crucial importance is that endothelin-1 is not only produced by endothelial cells, but is also produced by leukocytes. So white blood cells infiltrating a terrain propitious for inflammation are going to play an important role in the imbalance between relaxing factors, nitric oxide that is scavenged by the hemoglobin, and an excess in endothelin-1 induced by the production by the white blood cells and the endothelial cells. But as I said before, all these mechanisms are centered in the contraction of the artery, and the spasmocentric model of vasospasm is no longer the way we should approach the problem. And lights to this came, as I mentioned before, from the clinical trials, but also from the clinical observations. We are all aware of how patients who present with higher or poor grades of subarachnoid hemorrhage usually have worse courses during their hospitalization, and this is not only due to the acute ictus, but they frequently have higher incidence of vasospasm and delayed neurological deficits. In a paper that I published in the Journal of Neurosurgery a few years ago, when we were developing the vasospasm probability index, one of the main predictors of the presence of vasospasm was the hand and Hess at presentation. And this clearly indicates that something that occurs at the very beginning of the event marks, to a good extent, the destiny of individuals with subarachnoid hemorrhage. But what it is? I think there are new frontiers of the cerebral vasospasm research that have to be linked with those clinical observations. Early brain injury includes an elevation of the intracranial pressure and are going to induce a phenomenon that we will discuss in extent. It is well known, because we have had patients with subarachnoid hemorrhage that have ventriculostomy placed, or individuals with aneurysms with ventriculostomy placed that suffer either a rupture or a rupture of an aneurysm, that once the aneurysm ruptures, there is a sudden increase in the intracranial pressure. And this also has been extensively studied in animals. That increase of the intracranial pressure occurs for a period of time of around 3 minutes. During this period of time, the intracranial pressure is superior to the cerebral perfusion pressure, and no irrigation of the brain may occur. If the pressure doesn't get to be reduced, both in humans or in the animals, most of these individuals would die or develop permanent irreversible damage and eventually die. So the very beginning of the subarachnoid hemorrhage episodes produce an intrinsic head injury with a sudden increase of the intracranial pressure and a reduction of the cerebral blood flow. And this is thought to induce the non-flow or stop flow phenomenon, because during this period of time, up to 3 minutes, if the individual is going to survive, there is a stagnation of the microcirculation at the capillary level, producing increased blood viscosity, and this increased blood viscosity is going to induce the formation of microthrombi with adherence of granulocytes and platelet aggregates, which are going to induce vessels wall injuries. And this has been proven in several animal studies, and it has been observed in samples of the cortex of individuals with subarachnoid hemorrhage. Of special interest is this study published in 2002 in Neurosurgery by Hadeishi and his group, where 32 subjects were observed and no abnormalities were revealed by DWI in any of the low-grade subarachnoid hemorrhage patients. However, 71% of the patients diagnosed as poor grade subarachnoid hemorrhage based on the World Federation of Neurological Societies scale in grades 4 and 5 display multiple patchy focal abnormalities and the DWI in studies performed within 24 hours of the onset of symptoms. And what you're seeing here are scans within the first 24 hours of patients with poor grade subarachnoid hemorrhage, and what they show is this diffuse pattern of DWI abnormalities that most likely is due to that microvascular presence of thrombi and ischemic events in the cortex. As you also well know, not all the DWI abnormalities are permanent. Many of them disappear with time, but many of them remain. And what is clear is that the non-flow or stop-flow phenomenon is going to condition the brain to be more susceptible for further insults. And in these conditions, somebody with angiographic vasospasm and reduced cerebral blood flow is more susceptible to suffer delayed neurological deficits and permanent strokes. This gives us a little bit of light regarding that observation that even though 70% of patients may develop angiographic vasospasm, only 30 to 50% of them actually develop clinical vasospasm or delayed neurological deficits. A second very interesting phenomenon associated with this is, or has been suggested to be, the cortical spreading depression. The term cortical spreading depolarization describes the wave of near complete neuronal depolarization and neuronal swelling in the brain that is ignited when passive cation influx across the cellular membranes exceeds the ATP-dependent sodium and calcium pump activity. As I mentioned before, in the acute moment of the subarachnoid hemorrhage, there is depolarization of these muscle cells, and there is also depolarization of the neurons. This depolarization induces calcium to be flowing inside of the cells, and this very easily can exceed the ATP-dependent sodium and calcium pump activity. The cation influx is then followed by water influx and shrinkage of the extracellular space by 70%. In the normal ion homeostasis, what occurs is that the regular balance is restored through additional recruitment of sodium and calcium pump activity, and in that way the cell swelling is avoided. However, if this doesn't occur and the calcium influx is pathological and overcomes the capacity of the ATP pumps to release the ions from inside of the cell, then the water is going to accumulate inside of the cell and produce cytotoxic edema. That, by the way, is the way that it looks exactly in the DWI as in the studies that Hadeishi performed. Now, in physiological conditions, the energy consumption increases since the sodium and the calcium pumps are immediately activated to correct the intracellular sodium and calcium surge. In order to increase oxygen and glucose availability to supply the higher demand for ATP pumps, the cortical spreading depolarization induces dilatation of resistance vessels in healthy tissues. So when there is a cortical spreading depolarization, the normal response that you will find is an increase in the cerebral blood flow. Now, the opposite to this physiological hemodynamic response to cortical spreading depolarization, which is called inverse hemodynamic response, occurs when there is a local dysfunction of the microvasculature. And what we have in these patients, as we have described, is an abnormal microvasculature, most likely induced by that stop flow phenomenon at the beginning of the events. With the inverse hemodynamic response, severe microvascular spasm instead of vasodilation occurs and is coupled to the neuronal depolarization phase, and the resulting spreading perfusion deficit in turn prolongs the neuronal depolarization. Accordingly, the term cortical spring ischemia then describes the cortical spring depolarization-induced perfusion deficit. And in a very interesting study published by Dreher and his colleagues in Brain in 2009, this has been shown in individuals, human individuals with subarachnoid hemorrhage. This slide basically describes some of those results. You see the EEG readings in the top, and then the EKG readings on the top, and the regional cerebral blood flow measurements done by laser Doppler flowmetry of these optodes linked to the electrodes as shown in the pictures below, which were placed intracranially for patients with subarachnoid hemorrhage. And as you can see in the asterisk, when the cortical spring depolarization occurs, what you would expect in a normal individual with normal microvascular reserve would be an increase in the cerebral blood flow. But as below the regional cerebral blood flow graphic is shown also by asterisk, what occurs is an inversion and a paradoxical reduction in the flow, which is the cortical spring ischemia. In summary, the phenomenon of subarachnoid hemorrhage and vasospasm goes way beyond the contraction of the arteries that can be measured and visualized in cerebral angiograms. Of course, if there is a significant reduction of the flow by the susceptible days after subarachnoid hemorrhage induced by contraction of the arteries, brain that has been damaged and conditioned negatively by the stop flow phenomenon and by the depolarization will suffer most likely and easily of ischemic strokes. But the picture of the pathophysiology of vasospasm after subarachnoid hemorrhage then is more complex than only those descriptions of the molecules that we have made involved in the contraction of the smooth muscle cell. Once the aneurysm ruptures, bleeding occurs for 1 to 3 minutes and then stops. But there is an acute increase in the intracranial pressure, release of platelets, white blood cells, and blood clot in the subarachnoid space. Clot forms immediately and starts disintegrating around day 3, time when the window for vasospasm occurs. Now, the acute increase in intracranial pressure is going to induce cortical spring depression, that is going to induce acute ischemia and microvascular constriction by the paradoxical effect that we have described. Is going to induce directly acute reduction of the cerebral blood flow by the non-flow phenomenon, inducing acute ischemia, which is going to induce reduction of the mitochondrial respiration and increase of the anaerobic glycolysis, which is going to contribute to the formation of free radicals. The non-flow phenomenon is going to play an important role in further damaging the microvascular circulation, which then cannot respond properly in the cortical spring depression. The microvascular constriction is going to induce addition of factors promoting an inflammatory response, including endothelin-1 produced by mononuclear leukocytes, and platelets addition and aggregation that are going to damage the vessel collagen 4, exposing the smooth muscle cells to elements of the blood that they are normally not exposed. This is going to clearly increase and alter the vascular tone by damage on the endothelial cell, and is going to increase the vascular permeability, which is going to induce not only vasogenic edema, but extravasation of fibrin and erythrocytes, which very well are going to contribute further down to the same effect that the blood initially poured into the subarachnoid space with the rupture of aneurysm will have, that is the erythrocyte breakdown and the oxyhemoglobin degeneration products. Now, to come back to that original blood that was deposited in the subarachnoid space, the white blood cells are going to induce an aseptic meningitis, increasing the endothelin-1 produced by the mononuclear leukocytes, and inducing the formation of superoxide anion radicals, which are also formed by the oxyhemoglobin, and in the presence of superoxide dismutase and the absence of catalases in the extracellular space are going to produce hydrogen peroxide that inside of the extracellular space of the smooth muscle cells or around the smooth muscle cells in the vessel is going to produce hydroxide radicals by the Fenton reaction and the iron-catalyzed Haber-Weiser reaction, which induce intracellular lipid peroxidation with decreased membrane integrity, increased blood-brain barrier permeability, vasoconstriction, and cell death. Now the ferric hemoglobin that is in the clot and disappears around day 3 is going to also produce bilirubin, and the ADMA asymmetric dimethylarginine is going to induce the production of boxes, and the boxes are related with the inhibition of the endothelin nitric oxide synthesis and also lipid peroxidation. "500 years BC, Hippocrates described a syndrome where people who suddenly suffer headache and then became speechless and lay down usually die by day 7. And unfortunately, still today, we have a significant amount of patients that when they suffer a severe onset of headache and become speechless, they lie down, and many of them still die by day 7, despite the profound understanding that we have of many of the mechanisms involved. However, the spasmocentric idea should be replaced with a more comprehensive understanding of the phenomenon of vasospasm and a global view to other mechanisms that can be related with it. Regarding the treatment of vasospasm, it's very interesting to see how, despite these medications that are available, not too many significant advances have really been made. Because yes, we have medications that control the spasm of the arteries but don't have effect in the clinical course of the patients, and other ones that may have a mild effect in the clinical course of the patients but don't address the complete picture of individuals with vasospasm. So for the residents, I strongly recommend to review the updated guidelines for the management of aneurysmal subarachnoid hemorrhage, which were published in Stroke in January of 2009. And I want to just mention some issues that have to do with the endovascular approach to vasospasm from the diagnostic perspective and from a therapeutic perspective. From the diagnostic perspective, the development of a new focal deficit unexplained by hydrocephalus or rebleeding is the first objective sign of symptomatic vasospasm. Unexplained increases in the mean arterial pressure may occur as the cerebral arterial autoregulation attempts to improve cerebral circulation to prevent ischemia. Even though it doesn't have a perfect accuracy in the detection of vasospasm, transcranial Doppler is a valid form of monitoring for vasospasm, and these limitations can be improved by the use of the Lindergard ratio or the spasm index. However, further research is necessary to improve the efficacy of the detection of vasospasm and avoid the indiscriminated treatment with triple H therapy of patients that may not need it. Angiography is still the gold standard, however, it cannot be performed at will. Selecting the patients for the adequate management is absolutely crucial, and at this time our interventions are basically directed to everybody with subarachnoid hemorrhage in an attempt to try to avoid vasospasm. Therefore, tools that could predict better the presence of vasospasm and maybe integrate the new knowledge that we have in the pathophysiology of vasospasm to do those predictions could be crucial in treating better these patients. Now, as you will know, in our ICU we offer the state-of-the-art treatment for these individuals, and we are in general very successful treating them. However, there are still a lot of things that we need to do. We need to address the possibility of the role of endovascular treatments for individuals with vasospasm. And unfortunately, all we have is class 2B evidence for the interventions that we have available. And this is not well established utility or efficiency with conflicting evidence from non-randomized studies or single randomized trials. We know that balloon angioplasty has been shown to be effective in reversing cerebral vasospasm, but its effects and safety is limited to large proximal vessels with thick muscular walls, whereas angioplastic is not effective or safe in distal second-order branches. There are still significant risks associated with angioplasty of cerebral vessels, such as vessel occlusion, vessel rupture, thrombus formation, and aneurysm clip displacements. we perform intraarterial injections of verapamil as a calcium channel blocker to treat these patients. And although they appear to be safer than papaverine, their utility has not been established at this point. Curiously enough, there is only one treatment that is FDA approved from the endovascular perspective to treat vasospasm, that is the use of the coaxial aortic balloon. And this is based in a study performed by Pedro Lilik, where 20 out of 24 symptomatic patients show a 2-point or greater reduction in the NIH stroke scale score 20 minutes after the inflation of two balloons, one that is suprarenal and another that is infrarenal, as shown in the picture, in 14 patients, and the reduction and improvement was more than 4 points. Interestingly enough, the mean reduction following the procedure was 3.4 points, and the response was sustained through 30 days, even though the inflation of a balloon is done only for 40 minutes. We offer also this option of treatment for patients that fail medical therapy. But I think, once again, the clinical perspective should give us new lights in the pathophysiology of the phenomenon, and the analysis of why there is a response that is sustained after the inflation of the balloon could be crucial to better understand possible mechanisms to control vasospasm. In summary, from 500 years before Christ's era until today, even though we identify much better the mechanisms related with vasospasm, we still have a lot of work to do and research to perform to try to improve the understanding of this syndrome, which complexities go beyond the simple spasm of the arteries, and a significant amount of work to do to improve the therapeutic strategies that can help us to continue saving individuals and significantly, hopefully, improving the outcomes after subarachnoid hemorrhage.